Guys, welcome to the Cardio MedSoc tutorial. My name's Isha, I'm one of the fifth years, and I'm just going to be taking you through the first part of this tutorial, and then Loki and Umar are going to take you through the rest of it. So today we're going to be covering a bunch of the commonest long-term and acute conditions within cardiology. So these are some of them. Now, of course, cardiology is super broad, so we're probably not going to have time to go through everything, but we're going to be looking at hypertension, myocarditis, atrial fibrillation, heart failure, and some other stuff. And we'll basically be asking you SBA style questions, and then we'll take you through the answers. And if you guys have any questions at any point, feel free to unmute yourself or type your questions into the chat. And we'll also have some time at the end to go through anything. So question 1. A 57-year-old man comes in for a medication review. His past medical history includes chronic kidney disease, stage 3, hypertension, and gout. His current medications are amlodipine 10 milligrams daily and allopurinol 100 milligrams daily. His blood pressure today is 151/93, and a recent urine dip was normal, and you can see his bloods just below. So, okay, I'll give you guys about 50 seconds to look through the question, and if you want, you can type your answer into the chat, and then we'll go through it. Okay, does anyone want to try and answer at all? Feel free to unmute or type anything into the chat if you want to. Okay, so this question was about the management of hypertension, specifically hypertension guidelines. The answer was C. So adding ramipril, the ACE inhibitor. So let's go through it. So it's a 57-year-old man. He has chronic kidney disease, hypertension, and gout. He's already on amlodipine, which is a calcium channel inhibitor, and his blood pressure is 151/93, which is clinical hypertension. If you look at his bloods are okay, but his creatinine is increased and his EGFR is reduced. So in terms of the management, his blood pressure is clearly uncontrolled under his current medication, so you can't do option A. In terms of adding benzoyl-flumethazide, that's not the next recommended medication. And in terms of options D and E, in hypertension management, you typically don't want to stop the medication that you're currently giving. You just want to add the next line on top. So that's why C, which is continuing the current medications and adding ramipril, is the next best option. If options D and E involved continuing the amlodipine and adding the other medications on top, they would also be correct. It's also important to notice in this question, indapamide is the thiazide-like diuretic, and benzoyl-flumethazide is a thiazide diuretic. And they're quite different in the management of hypertension. You mostly only use thiazide-like diuretics. So these are the NICE guidelines from 2022 in terms of controlling hypertension in adults who are already taking step 1 of the management. So you can either add in an ACE inhibitor, an angiotensin receptor blocker, or a thiazide-like diuretic to the calcium channel blocker. So I'm sure you guys have seen this diagram before. This is the general management of hypertension. So there's 2 categories of people in terms of step 1, patients who are under 55 or diabetic, type 2 diabetic, or patients who are over 55 with no type 2 diabetes, or they're of Black African or Afro-Caribbean ethnicity. If a patient does have diabetes, it's important to note that you always want to prioritize that over any other demographic factors. And so a patient who is maybe 60 but with diabetes would be given step A, which is ACE inhibitor or an ARB. And yeah, as you can see here, the patient was already started on a calcium channel blocker, and then we can add in either option A, which is the ACE inhibitor or the ARB, or the thiazide-like diuretic. And this is the general management of hypertension in adults. So if a patient comes in with a blood pressure which is under 140/90, that's pre-hypertensive. So you'd want to keep an eye on their blood pressure by checking it at least every 5 years or so, probably more often in general practice. If a patient comes in with a blood pressure between 140/90 to 179/119, that is clinical hypertension. However, you'd want to do an ambulatory blood pressure first, just to make sure that there's no other factors affecting it. And you'd also want to investigate for target organ damage and cardiovascular risk. And if a patient presents with a blood pressure of 180/120, that's severely hypertensive. And the first thing you'd want to do is check for any signs of target organ damage, such as retinal hemorrhage or suspected pheochromocytoma or anything like that. If you do see any signs of end organ damage, such as retinal hemorrhages on fundoscopy, you'd want to immediately refer them for same-day specialist review, because that can be quite dangerous. Otherwise, you want to begin management immediately, probably on the day, and repeat clinical blood pressure within 7 days to check that the blood pressure has gone down. So moving on to question 2. A 51-year-old man is started on lisinopril, which is an ACE inhibitor, 20 milligrams, by his GP for an ambulatory blood pressure of 163/93. At his follow-up, repeat bloods are reviewed, and you can see these in the table below. What is the next best action with regards to his hypertensive medication? So once again, I'll give you about 40-ish seconds to think of the answer. And feel free to type it in the chat or unmute and speak. Okay, so in this patient, the correct answer was to reduce the dose of lisinopril to 10 milligrams. So if you look at the bloods, you can see first of all the potassium's increased from 4.2 to 5.2, which is quite significant. Also, in terms of the creatinine, is increased from 93 to 124, which is an increase of 33%, and the eGFR has decreased by 24%. So that's not quite an AKI, because an AKI would typically be an increase in creatinine of at least 50%. But it is a significant increase in creatinine. So here, if we look at the NICE guidelines for ACE inhibitor monitoring, once you start an ACE inhibitor, some increase in serum creatinine and potassium is normally expected. So a little bit of increase is normal, and you don't want to change anything. An eGFR decrease of less than 25% or a serum creatinine increase of less than 30% is okay. You don't want to modify the ACE inhibitor, but you do want to recheck levels in a further 1 to 2 weeks, just in case the serum creatinine has increased even more or the eGFR has decreased even more. And then, as in our patient, the serum creatinine increased by over 30%. That's sort of borderline. Therefore, you don't want to stop the ACE inhibitor completely, but you do want to reduce the dosage. So as you can see in red, you'd want to either stop the ACE inhibitor or reduce the dose to a previously tolerated low dose, such as the 10 milligrams ramipril. And before you do this, you'd also want to investigate for other causes of deteriorating renal function, and also stop any nephrotoxic drugs that they might be on, or any diuretics. And in terms of serum potassium, if the serum potassium is above 5, you'd want to investigate other causes of hyperkalemia. And once you've done this, if it's still high, then you might want to either reduce the dosage of ACE inhibitor or stop it. If it's above 6, you would stop ACE inhibitors immediately and treat for hyperkalemia. And if after decreasing the lisinopril dosage, the abnormalities you use in these persist when you recheck after about 5 to 7 days, then you'd want to start the patient on an alternative medication from the step 1 of hypertension management, so such as an angiotensin receptor blocker or a calcium channel blocker. And I've also just included the references for AKI. Okay, so these are some of the side effects of common antihypertensives. So this kind of thing gets tested really often under UCL. For ACE inhibitors, they like to talk about the dry cough, the hyperkalemia, and it can exacerbate any renal impairment that the patient might have, or it can even cause an AKI, as in the other patient it almost did. They can also talk about angioedema, so that can present with things such as swollen lips. With angiotensin receptor blockers, you don't see as many side effects, but you can still get the hyperkalemia and you can still get renal impairment. With calcium channel blockers, there are different types and they can have different symptoms. However, the key ones to remember are ankle swelling and bradycardia. In terms of thiazide-like diuretics, there are lots of side effects. I'd say the key ones to remember are hypokalemia, impotence, and impaired glucose tolerance. So you can still prescribe thiazide-like diuretics to diabetics. However, you just want to be quite careful with it, make sure that they have good glucose tolerance and review it quite often. In terms of beta blockers, it can exacerbate heart failure, it can cause depression, and it can cause erectile dysfunction, and spironolactone can cause hyperkalemia. Okay, so question 3. A 54-year-old man is admitted following a ST-elevated myocardial infarction. He's treated with a successful angioplasty. What advice should you give him regarding driving? And once again, I'll give you a couple moments. And feel free to pop any questions on the chat if you have any. Or if you want me to go slower. Okay, so in this patient, the advice he should be given is that he can't drive for 1 week. So in terms of car drivers, if they have a heart attack or a coronary angioplasty, they don't need to tell the DVLA, but they must stop driving for 1 week if they've had angioplasty and it was successful and they don't need any further surgery. If they've had angioplasty and it wasn't successful, or if they had a heart attack but didn't get angioplasty, then they need to stop driving for 4 weeks, but they still don't need to tell the DVLA. In terms of any bus, coach, or lorry drivers, they must inform the DVLA and stop driving for at least 6 weeks following a heart attack or a coronary angioplasty. Okay, so moving on to question 4. A 56-year-old woman visits her GP to discuss her ischemic heart disease, which was diagnosed 8 months ago. On questioning, she reports that her chest pain is ongoing despite starting medications. An ECG is performed and shows no acute changes. She's currently taking 5 milligrams bisoprolol, which is a beta blocker, once daily, and GTN spray as required for the chest pain. She also takes daily aspirin, atorvastatin, and ramipril. What's the next appropriate step in her management? And for this question, there are multiple answers that could be correct, but think about what the next step would be. Okay. So the next best step would be to add modified released nifedipine. So this would be in combination with a beta blocker. And the nifedipine is a non-rate limiting calcium channel blocker because you don't want to ever combine a rate limiting calcium channel blocker with a beta blocker. And we'll go over this in a bit. In terms of the other options, isorboid mononitrate, nicorandil, and PCI are all options that could be used in her treatment, but they would be used further on. They would be used sort of as an alternate to second line management as opposed to first line. And in terms of option D, keeping the treatment the same, because she's having ongoing symptoms, if you don't add anything to her treatment, then that increases her risk of acute coronary syndrome. So that would be inappropriate. So this basically summarizes the pathway for anti-anginal medication. So all patients with angina should be started on aspirin or anastatin just to reduce their cardiovascular disease risk. And they should also be given sublingual GTN, which is to use episodically whenever they experience any symptoms. And they should be told when starting the GTN that if they start to experience symptoms, they should stop whatever they're doing and rest, and then spray the GTN inside their mouth, wait for 5 minutes, And if the symptoms don't reduce, or if they even get worse, then they should do one more spray, wait 5 minutes again. And if the symptoms continue to go on, then they should call for help, call the ambulance, because they could be about to experience an acute coronary syndrome. So in terms of the first line, you can either give patients a beta blocker or a rate-limiting calcium channel blocker, and that just depends on patient demographics and just clinical expertise. And after starting them on these medications, you'd want to review the response to treatment after 2 to 4 weeks to check if they're still having symptoms and if they're experiencing any really bad side effects. And at that point, if they still are experiencing the symptoms, you'd want to start them on the alternate drug. So if they're on a beta blocker, you'd want to start them on a non-rate limiting calcium channel blocker. So also at this point, it's important to note that the first line management in terms of calcium blockers is a rate limiting calcium channel blocker, whereas the second line is a non-rate limiting calcium channel blocker. And if the patient is intolerant to both or either of these, then you'd want to start them on any of the alternate second line medications, such as ivabradine, nicorandil, and any of these. And then following these therapies, if they're still experiencing symptoms, then you'd want to refer them for PCI, for consideration of PCI. So just some further notes on treatment. If you've started the patient on dual therapy and they're still experiencing symptoms, it's important to check that they're definitely taking the maximum licensed dose of each drug. And if that still doesn't help, then you refer them for revascularization. And you can start a third anti-internal drug. So you can add, for example, nicorandil to a beta blocker and calcium channel blocker whilst waiting for the specialist assessment to help control their symptoms. And all patients who have angina should also be considered for secondary prevention. So you should consider antiplatelet treatment in these patients. And for most patients, this will be low dose aspirin, 75 milligrams daily. Patients with stroke or peripheral arterial disease might take clopidogrel instead of aspirin. And you should also consider treatment with an ACE inhibitor for patients who have stable angina and diabetes mellitus. Okay, so calcium channel blockers. There's two different types of calcium channel blockers. You can get rate-limiting calcium channel blockers or non-rate limiting. And the key distinction, to kind of summarize, is that rate-limiting tend to have larger effects on the heart, whereas non-rate limiting tend to have larger effects on vasodilation. And that's why you kind of want to avoid rate-limiting calcium channel blockers or non-dehydropyridines in any cardiac condition where the heart contractility is already compromised, because it can potentiate this even more. It can cause a lot of bradycardia. So you want to avoid it in heart failure, any sort of AV block. And you also don't want to prescribe it with beta blocker use because the combined negative chronotropic effects may cause further heart block or bradycardia. You can, however, use it in hypertension. You can use it for monotherapy in stable angina, and you can use it in arrhythmias to control the rate of the heart. In terms of non-rate limiting calcium channel blockers, so examples include amlodipine and nifedipine. These are very useful for hypertension, dual therapy and angina, and they can be used in controlled heart failure. However, in uncontrolled heart failure, you don't want to use either of the calcium channel blockers. You also have to avoid non-rate limiting calcium channel blockers in severe hypotension and cardiac outflow obstruction. And yeah, the main side effect of rate limiting calcium channel blockers are such as bradycardia, and the main side effect of non-rate limiting calcium channel blockers is peripheral edema. So moving on now to question 5. A 70-year-old man with a past medical history of osteoarthritis and asthma attends his routine annual health checkup. He doesn't complain of any symptoms, and his examination is normal apart from an irregular pulse. An ECG confirms your diagnosis of atrial fibrillation. After ruling out any underlying causes of his atrial fibrillation, you decide to commence him on treatment. Which of the following drugs should you prescribe to achieve rate control of this man's atrial fibrillation? So I'll just give you a few moments. Okay. So the best drug to prescribe in this situation would be verapamil, which is a rate-limiting calcium channel blocker. The other options, amlodipine is not a rate-limiting calcium channel blocker, so it wouldn't be helpful for atrial fibrillation. Atenolol is a non-cardioselective beta blocker, and it can provoke bronchospasm in asthmatics, so you wouldn't want to prescribe it in this situation. Digoxin is used in atrial fibrillation, however, it's not first line, so you wouldn't want to prescribe it here. And rivaroxaban isn't used for rate control as it's a DOAC, so you'd use it for prevention of stroke and embolic diseases. So we'll have a look at one more question, and then we'll talk about atrial fibrillation. So a 65-year-old man is calls an ambulance due to feeling dizzy and like his heart is racing. He's subsequently taken to A&E. He had an MI 3 years ago. Below is his ECG. His vitals were measured. His heart rate was 155 and his blood pressure was 95/65. So you've done an ATE assessment. What's the next most important step? Taking a look at the ECG as well. Okay, does anyone want to have a go at interpreting this ECG? Feel free to unmute if you do. And it's fine if you get it wrong. I think ECGs are quite hard to interpret. Okay, if not, I'll just try and talk through it a little bit. So with any ECG, you want to start off by confirming the demographics of the patient. Of course, we don't have that here, so we don't need to do that. After that, you want to look at rate, rhythm, and any axis deviation. So looking at the rhythm strip, you can kind of immediately see that the rhythm's quite irregular. So if the rhythm is irregular for rate, the best way I think to determine the rate is to count all the QRS complexes and multiply that by 6 because the rhythm strip is usually about 10 seconds. So in this case, I think there's about 18 QRS complexes. So that gives you a heart rate of about 18 times 6, which would be around 108. So the patient is quite tachycardic. If we look at the rhythm, we can see that it's irregular, and it seems to be irregularly irregular because you don't see any rhythmic dropped beats and you don't see any consistent length of PR interval prolongation. So that's how you know it's irregular, but it's irregularly irregular. You can also check for axis deviation, which isn't as important when you're suspecting atrial fibrillation. You'd also want to look then at the QRS complexes, and we can see that they're quite narrow. So they're about 1 square, which is quite tachycardic. Quite narrow QRS complex. And when you're looking for a P wave, you can also see that there's very little evidence of P waves. So there aren't P waves preceding the QRS complexes. So with that information, looking at this question, you would want to suspect atrial fibrillation. And the answer for this question was D. So looking at the ECG again, we can see that the arrows point to the QRS complexes, which are irregularly irregular, and the circles show that there's no P waves before many of the QRS complexes. And the typical description of an ECG for atrial fibrillation is having narrow QRS complexes, an irregularly irregular pattern with no distinguishable P waves. And in this gentleman, the reason that you'd want to give him DC cardioversion is because he has a lot of features of hemodynamic instability. So he describes feeling dizzy, he has quite a low blood pressure at 95/65, and his heart rate's also quite high. So let's go over the management of atrial fibrillation. So starting with hemodynamically stable patients, so unlike this gentleman, if the onset is under 48 hours, you want to do two separate things. First, you want to assess their stroke risk. So you want to calculate their CHA2DS2-VASc score, which we can go over in a sec. And you also want to maybe do a transthoracic echo. And depending on the score, if you have a female with a score of at least 2 or over, or a male with score 1 or over, you'd want to consider them for anticoagulation. Otherwise, there's no need to anticoagulate. In terms of the anticoagulation that you want to provide them, DOACs are typically first line for anticoagulation atrial fibrillation, and this is just because they're more effective, they're more safe than vitamin K antagonists. However, because they are primarily renally excreted in most cases, for patients with CKD, you might want to consider a vitamin K antagonist, such as warfarin, for example. Once you've assessed their stroke risk, you'd want to control the fibrillation. So in patients with the onset of less than 48 hours, this can be either rate or rhythm control, but usually rate control is preferred. So in terms of rate control, you can either use beta blockers or rate-limiting calcium channel blockers, such as verapamil. Beta blockers are usually preferred unless the patient has asthma. If both of these medications are contraindicated, then you'd want to consider using digoxin. However, this is not nearly as effective as beta blockers or rate-limiting calcium channel blockers, especially during exercise. The patient can still experience symptoms. In some patients, you might want to consider rhythm control instead, and this can be done in two different ways. It can either be pharmacological or you can cardiovert them. So in terms of pharmacological management, you can use either beta blockers or amiodarone. And in terms of cardioversion, that can also be either electric or pharmacological. And then talking about patients who have an onset of over 48 hours, or it's not clear when they started this rhythm of atrial fibrillation, you'd also want to first assess their stroke risk using the CHA2DS2-VASc score and transthoracic echo, and then you'd want to use rate control. So rhythm control isn't an option initially for these patients. And for rate control, once again, either beta blockers or rate-limiting calcium channel blockers. For patients who are diagnosed with paroxysmal atrial fibrillation, so that's when you have symptoms of atrial fibrillation, but they terminate within 7 days by themselves, you can have a pill-in-pocket approach where you can give them either flecainide or sotalolol, and this is just to terminate any episodes that they might be having, so they can just take it whenever they experience fibrillation. It's important to note that flecainide can only be given if there's no evidence of structural heart disease in the patients. Okay, so on the left side, you can see the CHA2DS2-VASc score, and this is something that UCL will expect you to know by heart. But basically, for each condition, you get 1 point. For age, if the patient is aged between 65 to 74, they get 1 point. If they're aged over 75, they get given 2. And also, if they've had a stroke, TIA, or thromboembolism, they get given 2 points. And as I mentioned before, generally, patients who have a score of 1, they'll be considered for oral anticoagulants. And if they have a score of 2 or above, they will almost definitely be given oral anticoagulants. The only exception is if their score is 1 and the only point they've scored is for being a woman. In that case, they might not receive anticoagulation. So on the right side, you can see the Hasbled and the Orbit scores. So these are both scores which are used to assess the risk of bleeding in anticoagulated atrial fibrillation patients. And it's just to weigh up whether the risk of anticoagulating is worth the risk of bleeding, so having such as a hemorrhagic stroke or something like that. So in practice, different clinicians use different scores. I don't think either are really superior, but it's good to just have a little bit of knowledge of both of them. And this is just the scoring for both of them to assess the risk of bleeding, and you titrate that risk against the risk of emboli using the CHA2DS2-VASc score. And in acute atrial fibrillation, when the patient comes in, before you've carried out the full risk assessment, you usually want to start them on heparin straight away to reduce their risk of having an emboli until you know whether they have a higher risk of bleeding, at least. So now let's talk about hemodynamically unstable patients or patients who might need elective cardioversion. So signs of hemodynamic instability can include signs of shock, such as blood pressure under 90, which is probably one of the biggest signs that's used for shock in atrial fibrillation. Also, if they describe any symptoms of syncope, such as dizziness, if they talk about chest pain, or you can see ischemia on ECG, or if they have symptoms of heart failure, such as pulmonary edema. You'd want to immediately do an A-to-E assessment and call for senior help. These patients would then be given synchronized DC shocks, up to 3 shocks, and you check for conversion to sinus rhythm between each shock. And you'd also want to check for any electrolyte disturbances. Before the shocks, you'd want to start heparin if possible. And if after these 3 synchronized UC shocks, they're still not back to sinus rhythm, then you'd want to administer amiodarone, 300 milligrams over 20 minutes. And then if you need further treatment, then 900 milligrams over 24 hours. So you can also receive electrical cardioversion in hemodynamically stable patients if they prefer rhythm control, and that's the clinical decision that everyone's come to. If the onset of fibrillation is greater than 48 hours, then before cardioversion, you need to either anticoagulate them for up to 3 weeks at least, or you need to do a transthoracic echo. And this is basically just to look for any signs of emboli, because when you convert a patient from fibrillation to sinus rhythm, that's when there's the highest risk of an emboli escaping into the system and causing stroke. So it's important to either anticoagulate or check or do a transthoracic echo if it's been over 48 hours to reduce that risk of emboli and stroke. You can also cardiovert a patient using pharmacological cardioversion, and this using either amiodarone or flecainide. And then finally, for some patients who don't respond to antiarrhythmics or they don't want to use antiarrhythmics for whatever reason, as a sort of later resort, you can do catheter ablation. So in this, you insert a catheter through the groin up to the faulty pathways in the heart, and you ablate the faulty electrical pathways which are causing fibrillation. For this procedure as well, you need to start anticoagulating at least 4 weeks before the procedure to ensure safety. And after the procedure, patients have very little risk of atrial fibrillation. However, they still have whatever risk of stroke that they did before. So you need to continue anticoagulation probably for life in most of these patients. Okay, and that's everything I had to say. Loki, do you wanna?
Yeah. Okay. Hello. Can you hear me?
Yep.
Okay. Cool. So I'm going to go over heart blocks, heart failure, aortic stenosis, and like peri-arrest guidelines. Let me just share my slides real quick and see if that works. Does that work?
Yep.
No, 1 second. Cool. Is that working? That's working, yeah.
Yeah, it's just showing part 2.
Okay, fine. Also, I think you got a question on the Q&A part, Isha.
Oh yeah, okay. Do we need to learn the orbit or the Hasblad score? You don't need to learn the orbit or Hasblad scores by heart, but it would be good to just have a knowledge of the different components of cardiovascular disease within them. You do need to learn the Chad-Vasc score by heart, all the scoring for that.
No, that does not work. Okay. Fine. Okay. So please feel free to interrupt me at any point if you guys have any questions or if anything is confusing. Ideally, if you guys interact, that would be helpful. There's like a little, the next slide is kind of asking you to put the different ECGs into what kind of heart block that is. But if not, I'll just move on to the next slides and I'll explain it. So we can start with question 1. A 70-year-old gentleman who recently underwent a primary PCI 2 days ago develops ventricular tachycardia on the general ward. The ward doctor attending to him notes he has a pulse and no adverse features. He started on amiodarone and converted back to sinus rhythm. The infusion is continued for the next 24 hours. The next day, a repeat ECG is performed, which reveals progressive prolongation of the PR interval until there is 1 non-conducted P wave. What is the most likely diagnosis? Yeah. Just put it in the Q&A section because I don't know if there's a chat on this call, or you can unmute yourself and also answer that way. Okay, I'll go to the next slide. Oh, that's a new post. C. Yeah, okay, so C is the correct answer. So it is a, I haven't put in the answer for some reason, but yeah, it's a Mobitz type second degree heart block, Mobitz type 1, because the PR interval will progressively get longer, and then eventually one of the P waves will produce no QRS waves. Okay, so this is the second part. So there's 5 ECG strips here, and each one will represent a different kind of heart block: first degree, second degree, and third degree. If you know like what are the pairings for any of them, just put it in the chat or put it in the Q&A section, and then I'll give you guys about a minute or so, and then I'll go over it. Okay, I'm going to go through it now. So A is a 2-1 heart block. B is a third degree block, which is the same as a complete heart block. C is Mobitz type 1, the same as in the question. D is Mobitz type 2, and E is first degree. And I'll go into what exactly each one is in more depth, but I'll just sort of point out the features that I'm talking about. So if we look at C, we can see that PR interval here. So a long PR interval, a normal PR interval is between 3 to 5 squares. So it's 0.12 to 0.20 milliseconds. If it's greater than 5 small squares, then it's a prolonged PR interval. I think this one is already like 7 or 8. And then it gets longer here, and then in the next one, it just disappears. So we can say it's type 1. In the type 2 block, you have a normal or fixed constant PR interval. So the PR interval is the same every time. So it's about 1, 2, 3, maybe like 5 squares in each one. And then one of them will not conduct. In a first degree heart block, you just have a PR interval that's long. So it's greater than 5 small squares, and that's about it. And it's like a normal variant, and it happens in athletes. Third degree block is when you have a complete dissociation between the P waves and the QRS complexes. So the atria is conducting at its own rate, and the ventricles are conducting at their own rate. A 2-1 block is a second degree block. It's difficult. So 2-1 blocks can either be Mobitz 1 or Mobitz 2, but because there's only one PR interval before the block happens, it's quite hard to tell which one of those is. Okay, moving on to the next slide. Okay, so heart block. Heart block is basically when the AV node has problems conducting its electrical impulses across the whole, like across all of the heart muscle fibers, I guess. What normally happens is you have the SA node, and you get an electrical impulse here, which travels towards the AV node. So atria contracts, that produces your P wave, and then it goes to the AV node, which travels through the bundle of hairs and the Purkinje fibers, which are on the base of the ventricles, and that'll give you your QRS complex. In a heart block, what is essentially happened is that signal is delayed for longer than it should be, and that causes a heart block. Or we just reference that as a heart block. So the causes are numerous, but some of the common causes are normal. So in the first degree heart block, and even some 2-1, so second degree type 1, you can get athletes or people who do a lot of exercise, or maybe just from aging, those muscle fibers might get weaker, or there might be more strain on them, and so there's a little bit of a delay before the ventricles contract, and that's normal. And most of the time that's asymptomatic, and it doesn't require any treatment. You can get medications that cause heart blocks, and I've listed some of them here, like the digoxin, amiodarone, and the question that we just saw, where the person was treated with amiodarone, the side effect was that they had heart block. And you can also get it from a heart attack, so that's going to cause some kind of damage to your heart, and that will cause a delay in the signal. There's 3 different types. So there's first-degree heart block, second-degree heart block, which is split into 2 different types, and third degree, which is complete heart block. And the bottom 2, so second degree and third degree, are quite concerning, because if they're not treated, someone can basically have something we call sudden cardiac death, which is they might just drop dead. Let's go to the next slide. If you guys have any questions, once again, please ask. Okay, so I just have some ECG examples for the different types of heart block. So in the top left, you can see first degree heart block, and over here it's kind of hidden because you have the QRS complex, the T wave, and then there's a P wave that comes right after the T wave, and that's quite delayed. But again, it's fixed interval and it doesn't change, and so we'll say that's a first degree heart block. And then you have your type 2, no, second degree, I keep getting that mixed up. Your second degree heart blocks, which is Mobitz 1, Mobitz 2. And the main difference between them is Mobitz 1, the PR interval will keep getting longer, and then one of the P waves will not, it will not successfully go to the ventricles. And if you think about it, what's basically happening is there's a delay, and that delay keeps getting worse until it reaches a point where the delay is so bad that the signal just doesn't go through, and then it goes back to the start. And so again, it will go back to like the smallest interval, and then it'll keep getting, no, wrong one. It'll keep getting longer, and it won't conduct. And when it starts conducting again, it'll have the same pattern. Mobitz type 2 is it's kind of a problem with the bundle of His or the Purkinje fibers. So the PR interval, the atria, is contracting like normally with a normal length. But sometimes the atria doesn't get its signal through, and there's no QRS wave. So you can see it here. And I guess an easy way to distinguish between them is just think about the PR interval. Because if you're measuring the PR interval and it's the same, like in 2 or 3 ECG thingies, then it's not going to be type 1. And if it's getting longer, then it's probably type 1. But again, Mobitz type 1 can also look similar to a complete heart block, which I will get onto now. Okay, so third degree heart block is when there is a complete dissociation between the P waves and the QRS complexes. Essentially what happens is the sinoatrial node is sending a signal, but the ventricles are not receiving it at all. And so what ends up happening is the atria has its own rate, and it will be a fixed rate. So normally it's like 60 to 100. And in this example, you'll see there's like 1, 2, 3, 4, 5, 6 P waves, and they're all happening at regular intervals. And because obviously the reason we have the pacemakers like the sinoatrial node and AV node is to make sure that our heart rate is constant. All of our cardiomyocytes can actually contract on their own, and it's like a feature called automaticity. So what happens is the cardiomyocytes in the ventricles will be like, okay, nothing is coming from the atria, so they're just going to make their own rate. They're like going to guess, let me just contract anyways, because I need to contract in order to stay alive. So they'll do that, but it will be completely unrelated to the P waves contraction. And when that happens, we call it a ventricular escape rhythm. So when the ventricles are contracting at their own rate. it's an emergency, like if it happens, and if someone comes in with a complete heart block, almost always the treatment is giving them a permanent pacemaker. Because if for some reason the ventricles stop contracting on their own, the person will like go into asystole, like severe bradycardia, and then they can just die, I guess. Okay, so that's heart block, I think. I don't know if I have any questions. Okay, yeah, I don't have any. No, I have one more question on heart block, which, let's see, hopefully, I don't know if I've covered what you need to know with that information, but okay, let's try this question. So a 96-year-old female patient develops third degree, someone posted a question, okay, develops third degree heart block as an inpatient on the ward. She has a heart rate of 24 and is feeling dizzy. Her blood pressure is 78/68. What is the most appropriate immediate management? Okay, yeah, someone said A. I think that's the correct answer. Okay, yeah. So what's happening is this person has bradycardia, and I don't want to go too much into what you do when someone has bradycardia or when someone has tachycardia, because there's slides coming up with the guidelines, and I'll go through them when that comes up. So I'll just move on to the next question. Okay, a 53-year-old man with a history of asthma has an ECG which shows an atrioventricular mode re-entrant tachycardia. He's now been stabilized with no adverse signs, but his ECG is still showing this pattern. With a regular rhythm, initial vagal maneuvers have failed. What is the next best management step? A, wait 5 minutes to check for resolution. B, adenosine 6 milligrams. C, adenosine 12 milligrams. D, verapamil 5 milligram IV bolus. E, verapamil 5 milligram IV over 2 minutes. So if anyone knows what the answer is, just put it in the chat. I'll wait like 30 seconds. Okay, so someone move on. Okay, so basically, you would be correct. So normally, when someone has an AV-NRT, narrow complex tachycardia, first you try vagal maneuvers. If that doesn't work, you give them adenosine 6 milligrams IV bolus. However, this person also has asthma, which is a contraindication. So the correct answer is that you give them verapamil 5 milligrams IV over 2 minutes. Yeah, exactly. One thing I would add, I didn't write this question down, but what I would say is UCL is not going to expect you to know whether it's given as a bolus or over 2 minutes. At least I would be very surprised if that was the case. I would imagine that if they gave you a question like this, it would be identifying that asthma is a contraindication, and then saying that you would give them verapamil. And we definitely got questions about the resus guidelines and what to do like for ALS in our exams. So it is definitely like high yield and something worth understanding. Okay, so I'm just going to go over the resus guidelines. So I think there's a third one, but I only have these two up because those are the questions I did. So these are available on Resus Guidelines UK, their website. And it's a chart and it shows you what you do when someone has either tachycardia or bradycardia. And I mean, at the start, they're mostly the same. You do an ABCD approach. You identify and treat reversible causes. So there's 8 reversible causes, which are the H's and T's. It's like the reversible causes of cardiac arrest: hypoxia, electrolyte abnormalities, hypovolemia, hypothermia, and then toxins, cardiac tamponade, tension pneumothorax, and then I think it's thrombosis, but okay, interesting. So there were 4. But okay, so If they have any of those things and you identify it, you would attempt to treat that first. If they don't have it, so if we go through the tachycardia guidelines, if they have any signs of life-threatening features, if they're in shock, if they've passed out, so shock in this situation, shock would be, let's say their blood pressure is less than 90/60. Syncope, if they passed out, if they have any of these other things, what you'd do is you'd give them synchronized DC shocks up to 3 times. If they're stable, if they're able to talk and they have tachycardia, then you do an ECG. When you do the ECG, you want to see if it's narrow or broad. The reason you want to see if it's narrow or broad is because the treatments for a narrow complex can make someone with VT or VF worse. So if someone has a broad QRS, they might have ventricular fibrillation or ventricular tachycardia. And the treatment for that is amiodarone. If they have a narrow QRS complex, and so QRS complex, if I'm not wrong, is like if it's over 440 in men, it's broad. If it's over 460 in women, it's broad. But I have another slide that explains that anyways. Okay, so if it's narrow and if it's regular, then it's what we talked about earlier, which is AVNRT. And you do vagal maneuvers first. If that doesn't work, you give them adenosine. If that doesn't work, you give them adenosine 12 milligrams and then 18 milligrams. I have a question for you guys. If no one answers it, I can say the answer later. But when you give someone adenosine, there's something that you have to tell them beforehand. I don't know if you guys know what it is, but if you do, just leave it in the chat. If not, I'll get back to it later. If they have a narrow complex and it's irregular, then it's probably AF. And hopefully with everything Isha talked to you guys about, you know exactly what to do for that. Okay, and then bradycardia. So ABCD, again, reversible causes, treat them. If they have any evidence of life-threatening signs, then you give them atropine, 500 micrograms IV. And then if that doesn't work, you can try atropine again. And then you can also try transcutaneous pacing, and you'd seek expert help. If they're stable, but they have risk factors, so they have a heart block, then you'd still treat them as if they weren't stable. Yeah, okay, yeah, so exactly. So when you give someone adenosine, it feels like they die, like as it's being injected into their veins or whatever, they will feel like they've died for like 5 or 6 seconds, and you have to warn patients about that, because otherwise, I mean, they're not going to like it anyways, but otherwise it's going to be a complete shock. Okay, let's go on to the next question. How am I at time? Okay. A 60-year-old woman with a history of hyperthyroidism was being investigated on the ward for hypercalcemia. Shortly after being admitted, she developed pneumonia and was started on dual antibiotic therapy. Today, she reported chest pain, and her lead 2 of her ECG is shown below. What in her history may have been the underlying cause of this rhythm? Okay, so if you guys know what the answer is, put it on the chat. If you know what the name of this rhythm is, please also put that on the chat. Someone's answered, but I'll see if anyone says what the name of this rhythm is as well, and then I'll say what the answer is. Yeah, okay, yeah. So the name of this rhythm is Torsades de Pointes. I think I'm saying that wrong. And the answer is clarithromycin. One thing I wanted to say about this question is, and I mean, I think it's a sign of a bad question, but also UCL sometimes does it. But when you have a question and it tells you this is a patient, some like whatever, recently we've given them this new medication. Today they now have this symptom. I would say, like, a lot of the time, the reason that they are having that new symptom is because of the medication that they're being given. So it's kind of a clue. So if she's been on antibiotics, then most likely the cause is probably one of the antibiotics. So the rhythm is called Torsades de Pointes, but the risk of it is that it can become VF. So let me just go on to the next slide. Okay. Okay. Fine. So this is VF. And essentially what happened is clarithromycin increased the what is it? The QT interval. Oh, I was talking about QT interval earlier. I gave you guys the completely wrong intervals for QRS complexes. Okay, the QT interval is prolonged, and that's what caused the Torsades de Pointes, which eventually causes VF. The causes of someone having a prolonged QT interval can be remembered by this acronym, I guess, MATCH. So macrolides, antibiotics, which is erythromycin, clarithromycin, amiodarone, tricyclics, antidepressants like amitriptyline, chloroquine, haloperidol, and then also hypos. So like I'm going to say that wrong. Hypomagnesemia, hypokalemia, hypocalcemia, hypothyroidism, and hypothermia. They can all cause it. And then what else happens? Oh no. And then I'm going to talk about Torsades de Pointes. Okay. So Torsades de Pointes means twisting of the points, and it's a form of ventricular tachycardia that happens because the QT interval is prolonged. And the problem with it is that it can, in a very short space of time, become VF. And if it becomes VF, it becomes very dangerous because you can just suddenly die. The what you see on the ECG trace, I've listed some of the things. So you'll see that, I mean, it says evidence of PVT and QT prolongation. I'm not entirely sure how you'd see that, but you sort of see it go like up and down. And so the QRS complexes, some of them will be big and some of them will be small. And it will extend like that along the path. I think, no, actually, I'm not sure about that. Okay, so I have the treatment here. I've kind of hidden it. If anyone knows what the treatment is, put it on the chat. If no one does in like the next 20 seconds, I'll just go over it. Okay, the treatment is IV magnesium sulfate. All right, let's go into the next question. A 72-year-old man, yeah, okay, yeah, that's right. A 72-year-old man is referred to the outpatient clinic with a 9-month history of worsening breathlessness. He reports that his symptoms now occur when climbing the stairs or walking on an incline. He has no relevant past medical history. He is fully independent and volunteers at his local charity shop. A transthoracic echocardiogram reveals normal left ventricular systolic function, ejection fraction 60%, and severe aortic stenosis. What is the most appropriate next step in the management of this patient? So option 1 is doing a transesophageal echocardiogram, which is similar to a transthoracic, but it sort of goes into the esophagus. Option B is a TAVI, which is transcatheter aortic valve implantation. C is to repeat the TTE in 6 months to see if it's worse. D is an exercise test, and E is surgical aortic valve replacement. Okay. I'm just going to give it a minute to see if anyone else wants to write there what they think the answer is. Okay, so yeah, the answer is surgical aortic valve replacement. And essentially, this is aortic, well, it says it's aortic stenosis, but anyone who has symptomatic aortic stenosis will be treated for it. So if you have aortic stenosis and you're passing out or you're getting breathless, they will treat you for it. The reason for this is because in people who have severe aortic stenosis, if it's not treated, I think, oh, there's a statistic, but I don't actually remember it. I think I wrote it down somewhere. Give me one sec. Okay, there it is. So half of the patients with severe symptomatic aortic stenosis, if you conservatively treat them, they will die in 2 years. So someone's coming in and they're symptomatic, you just treat them. When you treat people, there's two options. You either give them a TAVI, which is transcatheter aortic valve implantation, which you guys might have seen while you're on placement, because they're very common. And like, if an older person comes in, they have aortic stenosis, they also have heart failure, they all have these other problems, they'll give them a TAVI. If someone comes in who is fit and well, or like is mostly independent, or is very active, they will give them a surgical aortic valve replacement. And the reason for that is just because, well, it's twofold, but one of the reasons is for people who already have other comorbidities, putting them through a surgery might not be very the risk benefits might not be worth it for them, because any surgery is going to have its own risks. Okay, so surgical aortic valve replacement. Okay, aortic stenosis. So let's see. Okay, so I don't know if I wanted to talk about anything here. There is a little thing here which is talking about how the symptoms of aortic stenosis appear when the aortic valve area is less than 1 centimeter squared. I'm not sure that you guys need to know that. I think as long as you're aware, what is aortic stenosis, what is the murmur that it causes. So it causes an ejection systolic murmur that's loudest over the aortic area, and it radiates to the carotids, has a narrow pulse pressure, and you have a slow rising pulse. As long as you know these things, and you know that to diagnose it, you need to do a transthoracic echocardiogram. And if it's symptomatic, you replace it, and you're fine. There are situations when some people are asymptomatic, but they have comorbidities where they'll treat them anyways. And there's some criteria for that, which has to do with their pressure gradient. But I'm not entirely convinced that you guys need to know that. Okay. If you guys have any questions about this, please let me know. This slide goes over all of the other murmurs. I'm not super familiar with them, to be honest, in 5th year. So I'm not going to go over them, but the slide is there if you guys want to have a look at it later and to have a read of it. Okay, question 6. So a 64-year-old man is brought in by ambulance due to increasing breathlessness. On examination, his O2 sats are 97% on room air, heart rate is 110, temperature is 37 degrees, and he has bibasal crepitations. His JVP is not visible. This is his chest X-ray. Which feature in this chest X-ray is consistent with the likely diagnosis? So, consolidation, foreign body visible in bronchi, deviated trachea, widened mediastinum, or alveolar edema. I'll give you guys like 30 seconds again. Okay, so I'll tell you what this is. This is acute heart failure, and this person's coming with these symptoms. They've got a chest X-ray, and there are like 5 signs in a chest X-ray that are important to recognize when someone comes in with with heart failure? Yeah, okay, yeah. So the correct answer is alveolar edema. It has another name, and some people call it bat wing opacities or butterfly opacities, but it's basically this, like, if you see like around the like the middle of the X-ray, you sort of have these like opacities all around, sort of not the midline, but this line here and this line here, and you call that alveolar edema. And the reason that happens is because there's an accumulation of fluid, basically. Okay, so acute heart failure. I have one slide on it which talks about the chest X-ray findings. If you guys have any questions, please do let me know. So you do an X-ray, and there's 5 signs, and the way to remember them is A, B, C, D, E. Alveolar edema is what we talked about just now. I have like a better example of it here. So it's highlighted here. You have your curly B lines, which are basically is like thin lines on the edges, and they're caused when fluid is infiltrating into the interstitium of the lungs. C is cardiomegaly, and cardiomegaly is whenever the heart is more than 50% of the width of the chest X-ray. Importantly, though, you can only assess it if it's a PA film. D is dilated, prominent upper lobe vessels. So it's just when these show up. And then E is pleural effusion. And the way to see that is when you have a blunted costophrenic angle. And that will imply that there's some fluid in the lungs. Okay, let's go on to the next question. Okay, a 67-year-old man presents with short dyspnea, orthopnea, and bilateral lower extremity edema. On examination, he has jugular venous distension, crackles in both lung fields, and an S3 gallop on auscultation of heart sounds. Which of the following options is the most appropriate diagnostic test to confirm the suspected condition? So A is a BMP, B is an electrocardiogram, C is a chest X-ray, D is, shouldn't say echocardiogram, I should say echocardiography, and E is cardiac catheterization. Let me just fix this. I don't know if that showed you guys the answer. Okay, yeah, the correct answer is D. So importantly though, so the first line investigation you would do for someone who comes in with heart failure is actually a BMP. So if this question said what would be your next step, the answer would be A. But because it's asking about the diagnostic test, the answer is echocardiography. Okay, so heart failure. Let me just do the slides again. Okay, so there's 2 types of heart failure. There's acute, which is new onset heart failure, or it happens when there's acute decompensation of chronic heart failure. And there's chronic, which develops slowly, and like it's sort of something you can predict. And then you also have either reduced ejection fraction heart failure or preserved ejection fraction heart failure. Reduced ejection is what a lot of people have, and it's what most medication tries to target and what it's useful for. A lot of medications that we use are not useful for heart failure with preserved ejection fraction. You can have either left heart failure, which shows up with these symptoms. So you can have waking up, so shortness of breath, waking up breathless in the night, fatigue, postural hypertension. You can have a right heart failure, which causes things like peripheral edema or abdominal distension. And your symptoms and signs, you'll have the ECG signs that we talked about, tachycardia, cyanosis, elevated JVP, people have an S3 heart sound, which is like a gallop. And then the first line investigation is the NT-proBNP test. And basically a BNP is a protein that's secreted by the ventricles when they are stressed out or when they're stretched. And so by finding out what the levels are in your body, it can kind of help you predict whether heart failure is likely or heart failure is unlikely. And then you'll do an echocardiography, which will tell you things like the ejection fraction, which is helpful for like planning treatment for the patient. And you also do like ECG, functional tests, bloods, just as part of your initial investigations. And then managing it. So the way I always remember like the management of heart failure is with this acronym ABAL, which is ABAL. And so A is an ACE inhibitor or an angiotensin receptor blocker, so ACE, ARB. B is beta blocker. A is aldosterone antagonist, like spironolactone. And then L is loop diuretic. And in heart failure, they really like to split up like what is useful prognostically. So what is gonna like improve your mortality, and what is going to just give you symptomatic relief. And so loop diuretics are purely for symptomatic relief. So when someone comes in and they have peripheral edema, they'll give them loop diuretics. And a lot of people who have heart failure will be on loop diuretics, but that doesn't actually improve their outcome as well. But these medications will. So usually you'll start people on an ACE inhibitor and a beta blocker first. And if they're still symptomatic, you'll give them spironolactone. With spironolactone, there is a risk of them getting hyperkalemia. So you'll monitor that. And if they have hyperkalemia, you'll take them off that, and then you'll start them on one of the third line drugs. And the third line drugs are they all have their own indications. So it says it here. So hydralazine nitrate is useful in people with African Caribbean descent. Ivabradine is useful when people have a low ejection fraction. There's something called Entresto, which is sacubitril valsartan, which is like being increasingly used now. And I think they're trying to switch a lot of people onto this medication because it seems to be quite useful. The other things that are important to know: anyone who has heart failure will have the annual influenza vaccine, and they'll always have a one-off pneumococcal vaccine. If it's very, very symptomatic, they might be eligible for a implantable cardiac defibrillator or cardiac resynchronization therapy, and these all have their own requirements. I think as long as you have a good idea of this happens, I'm going to add this, who is this medication more useful for? As long as you understand that at a basic level, I think you're going to be fine. There are two algorithms from a nice website that I've added in, which kind of summarize what I've said in a much simpler way. So diagnosing heart failure, take a history, measure their BNP. Depending on the levels, you'll do a transthoracic echocardiography. And then if they have heart failure, you assess the severity. And then this one tells you how to treat them. So everyone is going to get diuretics because it has symptomatic relief. It stops their legs from swelling. And if they have reduced ejection fraction, you'll offer them an ACE inhibitor and a beta blocker. If that's still bad, you'll give them spironolactone. And then these are the third line drugs here, and it gives you the indications for them. I think that's everything. We put this in the middle, but I don't know if we'll just show it at the end.
Yeah, we'll show it at the end as well.
Okay. But I think this one has the old QR code, so it might not work.
Okay, fine. Yeah, this one might not work then.
Fine. Okay. Let me just get the new QR code in that case. Okay, so if you guys have some time, we can do are we giving them a break or are we just cracking on?
What do people think? Would they rather a little break or just crack on and try and finish on time? I feel like we should try and finish on time if we can.
Okay, fine. In that case, I will hand it over to you then, Umar.
Yeah, that is
All right.
fine. Okay, hi guys, I'm Umar, another one of the fifth years. And I'll just let me just start my screen share. Okay, is this working? I can't quite see. Let me see. Is this sharing, guys? I'm not too sure.
Yeah, it's sharing.
It's sharing, and does it change slide?
So it's just on, yeah, it's changed slide now.
It's changed slide? Okay, that's fine. Okay, right, guys. Hi, I'm Umar. Hopefully, you guys are still kind of, attentive. I know it's 7:30. It's been a little bit over an hour and a half now, but I do appreciate if you guys, kind of participate as much as possible. Either put something in the Q&A or, speak out loud. The way I've used to find these sessions really useful is by participating, by asking questions of the fifth years. And just kind of, even if it's wrong, because honestly, last year, most of the stuff I'd get in these kind of SBA questions are wrong, but that's not the point of it. The point of it is to try and you remember what you get wrong more than anything else. So without further ado, we'll start off with this. So we've got, it's an amnesty question. I didn't make these slides, just a disclaimer, and I'm definitely not saying I would get this right in any scenario, but apparently previously this has come up in amnesty. It would have come up with a clinical vignette alongside it, but we've just kind of put it in there just to see if anyone has any ideas initially about what they might be seeing. So please feel free to speak up. Just say what you see. It's a picture of the heart. It's cardiac muscle. And I know that's not normally how you're used to kind of seeing cardiac muscle, but this is cardiac muscle and it's a biopsy of cardiac muscle. Can anyone have any ideas of what they might be seeing? Infective endocarditis. Okay, that's a good reason. Why do you think that? I'm going to be trying to make this as interactive as possible because honestly, it's the best way for you guys. It's the best way for me. It's the best way to kind of make this as entertaining as possible. Rheumatic fever. Okay, that's another good shout. You're all kind of thinking inflammation and inflammatory things that are going on with the heart. And in essence, you guys are right. And without a clinical vignette, it's pretty much impossible to get this. But essentially, what I'm trying to get you guys to see is if you see all these little white, or not white, but they look like little dots, little kind of circular things. When you see a lot of them in a kind of enclosed environment and they're more in one space than the other, it's more likely to be white blood cells. So I see what you're saying, gram-positive cocci and cardiomyocytes, and it could be, but I think in this case it's more likely to be white blood cells infiltrating a certain area. And then if white blood cells are infiltrating a certain area, it's more likely to be because of inflammation or infection. Now, the three common causes of kind of inflammation of the heart, or three conditions, do you guys know what they might be? And they all just refer to different, basically, sections of the heart. So if you think back to your anatomy of the heart, yeah, pericarditis, so that's the pericardium is the outer layer, the outer sac of the heart. So that's pericarditis. That definitely could be happening here. What's another condition that's kind of similar but a little bit different? It's also inflammation of a certain part of the heart. So you've got pericarditis, that's definitely one. You've got your pericardial layer, then you've got another layer before you get to your layer of, which is the valves and stuff like that. That's where you get your endocarditis. Between your endocarditis and your pericarditis, you have, yeah, exactly, myocarditis. So that's essentially what this is showing. And it's a mean question. It's a question that, histology does come up sometimes in your year 4 exams. It didn't come up much for us, I'll be real. It came up very sparsely, if at all. But it's something that, UCL can ask about, and it's something that, it's something to bear in mind, if not necessarily something to always, put hours and hours of work into. If you have a rough idea about different biopsies, and I think in renal, for example, there can be a few biopsy questions there with different kind of things, but essentially, yeah, myocarditis. So essentially, a young person comes in with chest pain would be the vignette normally. And then they might ask you kind of what virus is most commonly associated with it. In the UK, it's kind of Coxsackie B virus, which is the common cause of it. So with myocarditis, it's kind of inflammation of the myocardium, which is, so your pericardium is your outer sac, as I said, then your myocardium is the layer behind that almost. So it's inflammation of that area. As I said earlier, it's a young person more commonly with chest pain, shortness of breath, fatigue, these kind of systemic symptoms almost. A clue in the history will commonly be 2 weeks ago they had a cold. So very similar with pericarditis in that regard. 2 weeks ago they might have had a cold, and now they're presenting to you with these kind of chest pain-like features and symptoms like that. And then initially with any person coming in with chest pain, if this was your OSCE, for example, and they ask you, what are you going to do? You always obviously want to start off with saying, I'd like to assess this patient by my A2E approach, because any person coming in with chest pain, and in myocarditis, it can actually be quite severe chest pain. Sometimes it's not just mild. It can be quite, painful in some regard. So you always want to do your A2E approach, and investigations when it comes to the heart, chest X-ray and ECG are probably your top two that you want to do. ECG, obviously looking for any kind of ST changes, things like that. Chest X-ray, obviously looking for cardiomegaly or other features of maybe kind of heart failure and things like that. Now, with myocarditis, an important thing to note is that it can actually present with ST changes as well. So you might get a person coming in with chest pain, with ST elevation, but it is myocarditis. And in that scenario, you might think, well, it is obviously a STEMI, but what will happen more likely in myocarditis is that the ST changes will be more widespread. In both myocarditis and pericarditis, you'll have ST elevation in a few different leads, or maybe all the leads, whereas in ST elevation myocardial infarction, you'd get ST elevation in what they call the, you'll get leads associated with a specific artery. So for example, you'll get changes in 2,3 AVF, which will be linked to the right coronary artery, for example. Another thing with myocarditis, a way to differentiate it from, for example, pericarditis, is the troponin will be very high. So in pericarditis, you can get a little bit of a raised troponin, but in myocarditis, your troponin will be very high because, as it is, it's inflammation of the myocardium, and troponin is a marker of death of myocytes. So when you think about it like that, you'll expect your troponin to go really high in myocarditis. And then when it comes to kind of investigations, a question UCL could ask is, what is the gold standard of investigation? And in myocarditis, it's an endomyocardial biopsy. And in endomyocardial biopsy is where you'd get this picture and where they could even kind of ask you to diagnose it based off that as well, along with other information. They would never just give you the biopsy. I don't want to scare you guys too much. In terms of management for myocarditis now, it is generally supportive, and there's no kind of, you don't have to learn about loads of different management for it because it's effectively supportive. They will get better on their own. If there's an underlying cause, such as an infection or something like that, you treat the underlying cause. And then if there's complications that have occurred from it, treat heart failure or arrhythmias. And generally speaking, you just want to tell them, rest up and it should get better by itself. Exercise may make it worse. Things like that. So that's myocarditis. Okay, so here's our first question then. So Mr. S comes in for his repeat abdominal aortic aneurysm scan. Last scan was 12 months ago, reported the size to be 3 centimeters. Today, the AAA was 4.5 centimeters. He's clinically well with no symptoms. What is the most appropriate course of action? I'll give you guys 40 seconds to read it. And then put it in the chat, or unmute your mics. Honestly, I'm more than happy to hear your guys' voices. So yeah, go ahead. Okay, so we've got one answer for C. Anyone else want to put their answers in? And also tell me why you think it is that. Because it's really important when doing any kind of your PassMed or your QuesMed or random SBAs, guessing and getting it right is one thing. That's great. That's fantastic. We all love that. But in the end, what's going to help you most in your exams is if when you're doing a question, you know why you're getting that question right. So then you can apply it to another thing. Okay, another person's put B, thought surgery is for 5.5 centimeters. Okay, fine. So it's good. We've got some different answers here. That's exactly what we want. We want discussion. So basically, what's happening here is his AAA was 3 centimeters last year, and it is 4.5 centimeters this year. So in that period, there's been 1 year difference. Okay. Now, Githme, you are correct that you do generally do surgery for over 5.5 centimeters. However, in this scenario, it has increased by more than 1 centimeter over a year, as Mike correctly says, and that is an indication to refer kind of within 2 weeks to the vascular surgery team. So the referral criteria is there. Symptomatic patient with an aneurysm size of more than 5.5 centimeters, or an aneurysm size of more than 5.5 centimeters, or, as in our case, a rapidly enlarging aneurysm over 1 centimeter a year, as it is in this case. You would refer them to vascular. Does anyone want to explain to me or tell me what vascular would do in this scenario? It was at the bottom there if anyone saw it, but I've taken it away now. What kind of procedure they might do and why that procedure might help. That's fine if not. Okay, so what they would do is basically do an EVAR, which I think it stands for endovascular aneurysm repair, something like that. So what they're doing is they're placing a stent in via the femoral artery more commonly into the area where the AAA is. And what that's doing is that's basically diverting the blood supply from the stent or from the aneurysm through the stent instead. Because what happens is if you have loads of blood rushing through an aneurysm, and if you remember, an aneurysm is basically just a blood vessel that's dilated to a kind of 1.5 times the size, so 150% of what it was. So if you start to divert that blood from the aneurysm to the stent, it means that less blood's going to be going through the aneurysm, and that means that it's less likely to rupture. And obviously, a AAA rupture is kind of a severe cause of kind of death and more mortality. And you're trying to prevent that as much as possible. So this is a scenario where you would want to do a kind of EVAR stent, and that would help the patient quite a lot. Okay, next question. So a 49-year-old man who woke up with a weak arm and a leg, he was admitted to the hyperacute stroke unit. His OBS, 89 heart rate, blood pressure 184/83, respirate 16, 95% oxygen, and temperature of 36.5. His CT head was unremarkable. So after 2.5 days at hospital, he's being discharged. What other medication should be given in addition to aspirin 300 mg PO on discharge? So there's your 5 options. I'll give you guys 40 seconds to read it, and then again, put it in the chat or unmute your mics. Okay, I'll give you guys a few more seconds. Just remember, this is asking you what medication should he be given on discharge. That's the kind of hint in the question. Anyone got any answers? Okay, that's fine. So initially with a question like this, you want to be thinking first, what's going on? Okay, he's had a stroke. And then next, what is the question asking me? So the question asking me is what medication should be given on discharge? Instantly, when it's telling me that, what should be given on discharge, I've got 3 options ruled out because it's not going to be IV. So that rules out A, D, and E. With all questions that you're doing, you're basically just trying to whittle it down. And normally you will whittle it down to 2 options. And then between those 2 options, it could be a 50-50 or you'll lean towards one, but that's the way you should approach questions, because if you just look at an answer and instantly pick it without even looking at the other ones, then that's kind of recipe for disaster, because as UCL do, it's single best answer. It's not only one is right. Multiple could be what you think is the correct answer, but one is more right than the other. So in this scenario, it's a medication that we're going to give to someone on stroke, who's had a stroke, and what we're going to give to them is a statin. So in this scenario, we're going to give atorvastatin PO, and we'd give it as secondary prevention. So does anyone know what the two dosing regimens are of something like atorvastatin? There's two common doses we might use for different kind of, you know, anyone? Let's see. ATMG, yeah, fantastic. So ATMG is what we'd give as secondary prevention. So someone's had a cardiac event like a heart attack, or someone's had a stroke. More commonly than not, unless there's kind of contraindications or something like that, they're going to be given atorvastatin ATMG. Atorvastatin is the most commonly used one nowadays because it's kind of cheaper than the other ones that used to be used, simvastatin and stuff like that. But for someone who's kind of had no event, but they've got risk factors for it, they would be given the 20 mg. So for example, if someone has a Q risk of more than 10%, if someone has had kind of type 1 diabetes for 10 years, and there's a few other kind of criteria for that, but they would be given the 20 mg statin. And it's really important to note as well, statins, they reduce your risk of another event like this over a 10-year period. So that's just something to bear in mind. But yeah. Another thing in this question is the patient actually had a very high blood pressure, 184/83. I don't know if any of you guys picked up on that, but it is actually quite normal to have an elevated blood pressure after a stroke, because obviously the stroke has led to a hypoperfusion of the brain. So now once you're recovering from that stroke, you're going to have increased perfusion towards the brain and other areas, which is going to increase your blood pressure. So that's not necessarily something to worry about. Again, I didn't make this question, so I'm not 100% sure, but generally speaking, you would have a higher blood pressure after kind of an ischemic event like this, like a couple of days after. And yeah, it says at the bottom, so many physicians will delay treatment until at least 48 hours. So that's why it's important, because even with something like aspirin, I know this is kind of going off topic a little bit, aspirin, you might not always give kind of straight away because there's a risk of hemorrhagic transformation, but that's a neuro kind of thing more. But important thing to note here is atorvastatin ACMG is secondary prevention for stroke, and it's kind of it's a very important drug that you should know, because it could come up in a prescribing thing as well. And this is just some more little things on kind of statin treatment. Okay, next question. You are the ENT doctor seeing a lady with nosebleeds. She's had 2 episodes of epistaxis this morning. The bleeding has now stopped. Past medical history, she takes warfarin for her prosthetic heart valves. What is the most appropriate next step? And again, I'll give you guys a bit of time just to read up. Okay, we've got 1 answer so far. Anyone else got any answers? Okay, fine, brilliant. So yeah, we do have to send off bloods for coagulation studies, because realistically, we can't know what treatment to give this woman unless we know her INR. Let's see. Okay, someone's gone for B, and I understand why you can kind of think that, but you're trying to think of the kind of the management for warfarin with high INR. There's that big PASMED table, all that kind of stuff, but those are all based off when you already know the INR. The first thing you're going to do is send off bloods for coagulation studies. And you would probably tell her probably not to take a warfarin until you've done that. And then you can kind of be like know what level she's at. It's also important to note in this scenario that it is minor bleeding, because if they have major bleeding, So examples of major bleeding might include an intracerebral hemorrhage or a variceal hemorrhage. It's another kind of example of a major bleed. In that scenario, you would have to stop the warfarin, give vitamin K, and give kind of prothrombin complex concentrate, regardless of the INR. However, in this scenario, because it is a minor bleed, that's the scenario where we do have to work out the INR. Okay, so next question, we're going to get her INR back, and her INR is 6. So now what would be the treatment of choice? Give you guys a bit of time. Okay, someone's gone for C. Any other options? Okay. And here again, I want to say I didn't make these slides, I didn't make these questions, so I understand why you've gone for C, and I can definitely appreciate why. In this, they have gone for A as the option because I know they said the bleeding has stopped, but she still had 2 episodes of bleeding today. So I think you would still go down the pathway of the minor bleeding pathway instead of the no bleeding pathway, if that kind of makes sense, because she still had 2 episodes, and it's hard to know how much blood she's lost, and it's still that epistaxis could almost come back again, and she had 2 episodes of it. So that's why they've gone for the minor bleeding pathway. And in that, if your INR is between 5 to 8, you would kind of stop the warfarin and give IV vitamin K, and then restart the warfarin when the INR is below 5. So this is a little infographic on the kind of warfarin and management of high INR, because I think this is something that is it's important to know about, because as you can imagine, people on warfarin, if they have any kind of bleeding thing, that's going to affect them quite a lot. So firstly, what is INR? INR is basically international normalized ratio. It is effectively comparing someone's length of time to clot against a kind of standard number they have. So if you have an INR of 1, that's the kind of standard time it would take someone's blood to clot. If your INR is really high, it's going to take a long time for all that blood to clot, which means you're going to bleed a lot faster. And obviously, in a case, if you've already got, if you're bleeding at the moment and you've got a high INR, that is a much more worrying thing for you to think about. So here's a little the picture. When you're not bleeding at all, you have to look at the INR. Between 5 to 8, what you do is you'd withhold 1 to 2 doses of warfarin, and then you might reduce subsequent doses of warfarin if it's between 5 to 8. If it's over 8 and you're not bleeding, you're going to stop the warfarin. You're going to give vitamin K, but you're going to give it orally as opposed to IV. And then again, you might restart the warfarin when the INR is below 5, because INR above 8, even if they're not bleeding at the moment, that means their blood is going to take a long time to clot. So you really want to give them something to help with that coagulation cascade. That's why you're giving them vitamin K. But you don't have to give it IV because it's not as urgent. You can give it orally. But incidentally, it's actually made up with the same IV solution. Okay, now when you are bleeding, there's 2 kind of ways. So either you're bleeding and your INR is between 5 to 8. So in that scenario, as we had, you'd stop the warfarin, you'd give IV vitamin K. Incidentally, vitamin K, phytomenadione is the same thing. It's important to sometimes know there's multiple words for the same thing, and it can be a bit jarring almost sometimes if you see a word that you don't recognize, but when you look at the answer, that you've heard of the other word for it. But yeah, phytomenadione is vitamin K. So that's what you do if it's below 8. If you have minor bleeding and it's above 8, your INR, you're going to stop the warfarin. You're going to give IV vitamin K, so same as before, and then you might also give another dose of IV vitamin K 24 hours later if you found it's not helped. And as I said, for major bleeding, no matter what the INR is, you give vitamin K 5 mg, so a little bit of a higher dose, and prothrombin complex concentrate. Okay, so next question. And again, this is a bit of a mean question, but try your best. A woman is brought in by the paramedics being found unwell at her care home. On examination, she's feverish and clammy, splinter hemorrhages on both hands, and mild splenomegaly on abdominal palpation. What is the likely cause of her illness? But before that, what is the kind of rash that is on her? And what could it be indicative of? Think back to rheumatology a little bit for this rash. Okay, so I'll just go through it because it is a bit of a tricky one. So the rash is a malar rash. So that's most commonly associated with SLE. So yeah, malar rash, brilliant. So yeah, it's a malar rash of a kind of butterfly distribution rash that they call it. So when you have SLE, that can be a kind of trigger or a precipitant of so many different things. There's the kind of meme that, think lupus for everything that like House says, but like lupus genuinely can be associated with so many different things. And it can also be associated with, well, does anyone know what the condition is actually that's going on here? Splinter hemorrhages on both hands, splenomegaly, and she's feverish. What might the condition be? Infective endocarditis, brilliant. Yeah, so it is infective endocarditis, but in this question, actually, the answer is going to be a non-infective cause. And this is super niche. Liebman-Sachs endocarditis is associated with SLE. I would not class it as the highest yield thing there is to know, but I guess now you guys know it. If there's a malar rash in a patient and they have symptoms of infective endocarditis, Liebman-Sachs is the kind of terminology for it. Next question. So a woman is brought into the paramedics being found unwell on the street. Same stem as before, but this woman has track marks on her arm. What is the likely cause of her illness? B, yeah, B. Staph aureus is the most common cause generally, and it is also associated with kind of IV drug users. So, whatever you're reading in stems of your question, think they are, there's a hint to it in everything. So the track marks in her arm, IV drug user. Okay, I know IV drug user is associated with Staph aureus, so that's going to be the most common cause. Okay, and the next one. Honestly, whoever made these slides is very, very mean because this one is tricky, is very tricky. But again, just have a go. Okay, so in this one, the key kind of the hints are the poor dental hygiene, and that is effectively linking towards Streptococcus mitis, which is the more important thing to know in this actually it's this type of Strep viridans, which actually used to be the most common cause of infective endocarditis, but they've now found it's Staph aureus or something. But these are some of the different important ones that you might want to know about. I think Strep bovis being associated with colorectal cancer. That could be an important one to learn. And Staph epidermidis is basically associated with any lines. Someone's recently had a catheter, or they've recently had a kind of IV drip or a central line or something like that. Then you're going to be thinking epidermis, very commonly associated with that. And then Staph aureus, as we said, and then Streptococcus lactigni is a group B strep, which is a bit more associated with kind of like pregnancy and things like that. Okay, next question. A patient presents to ED with chest pain radiating to his back. He's been moved to resus with vital signs of a heart rate 110, blood pressure 180/90 with no specific ECG changes, and he continues to have chest pain and starts to have fluctuations in consciousness, what is the most appropriate investigation? And tell me what you think the diagnosis is as well. Appreciate we are getting towards 8 o'clock now, so we'll be wrapping up soon. Just the last question now, I think. Transesophageal echocardium. Yeah, brilliant. So this is a patient who's having aortic dissection, most likely, but also it's important that they are kind of unstable at this point. They've got extremely high blood pressure, they're tachycardic, they're continuing to have chest pain. So they're not a stable patient. So you're going to want to do a transesophageal echo for this patient because it can be done kind of more quickly. Whereas a CT chest, are you really going to be trying to take an unstable patient to a CT scanner, try and keep them still for that whole time? It's probably unlikely. But yeah, with aortic dissection, there's kind of two main types to it. There's the type A and type B. If you look at the standard classification, which is the more commonly used or the more easier one that I found to learn, with type A being a kind of ascending aorta dissection, whereas type B is more kind of the descending aorta. It is important to note that kind of a CT chest is commonly the first line investigation in a stable patient. And the important thing to know is also type A is treated surgically, whereas type B can be more conservatively. But both of the ones you're going to want to control the blood pressure with something like labetalol maybe. But I think that is everything. So if you guys could please kindly fill out this feedback form and ask away any questions to any of us, we'll be here for a few minutes at least to kind of answer anything you guys have. And thank you for listening as well and participating. Any questions from you guys at all? It can be anything, not just cardio. It can be any kind of general year 4 questions or general year 5 questions, I guess, if you're intrigued. But if there's not, I guess thank you guys again. And please do fill in the feedback form. It does help us a lot. And we do appreciate any feedback that you guys give, positive or negative. But yeah, enjoy the rest of your Tuesday then, guys. Unless there's anything that Loki or Isha you want to add. Other than that, no. Brilliant. Thank you guys then.